All right, good afternoon, everyone, and welcome to our July Teach Educational Rounds. Here with us today, we have Marilyn White-Camplbell and Dr. Aviva Rostsas, who will be presenting Clearing the Smoke, Tailored Tobacco Cessation and Safety Strategies for Older Adults with Co-occurring Illness and Cognitive Impairment. So I'll start off with our CAMH land acknowledgement. While I do this, please feel free to continue introducing yourself in the chat. We love to hear where you're joining us from, and I'll just get started. So CAMH is situated on lands that have been occupied by First Nations for millennia, lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. So again, please feel free to continue to introduce yourselves. I'll just put a link in the chat. If you don't know what traditional territory you're joining us from today, you can use this to find out. And in the meantime, I'll keep going with a few more reminders. So if you wanted to receive a letter of completion for this Teach Educational Rounds, we ask that you first registered for this webinar and completed the full pre-learning assessment. Also sign into this webinar using your first and last name, and to complete the evaluation and the post-learning assessment, and both of those will be sent out to everyone who registered at the end of this webinar. And a bit more about our presenters. So Marilyn White-Camplbell is the Geriatrics Addiction Specialist with Baycrest Long-Term Care Behavioral Support Outreach Teams. She is the Provincial Lead for Behavioral Supports Ontario Brain Exchange Older Adult Substance Use Collaborative, which co-authored Cannabis and Older Adults, Know the Facts. Marilyn was a co-investigator with Canadian Coalition for Seniors Mental Health Project, which established 4 national clinical best practice guidelines for SUDs in older adults. She is teach trained and is a strong advocate for smoking cessation supports in Ontario's long-term care homes. With over 40 years clinical experience working with older adults with SUDs, she is recognized as a pioneer in the field of geriatric addiction. Welcome back, Marilyn. We're excited to have both of you back as a follow-up from last year. And our second presenter, Dr. Rostsas, completed her psychiatry residency and geriatric psychiatry subspecialty training at the University of Toronto. She is currently on staff at the Centre of Addiction for Mental Health and works in the Geriatric Psychiatry Inpatient Unit in transitional housing for seniors and consulting to long-term care homes. She is an assistant professor of U of T's Department of Psychiatry. Welcome, Aviva, as well. And I'll give everyone a moment to read through both our presenters' disclosures, which are on the slide. And this is just a general note that all eligible Teach Educational Rounds presenters are offered an honorarium. That being said, acceptance of this honorarium does not impact presentation content. And the content of Teach Educational Rounds are centered on the following evidence-based guidelines. Nonetheless, these materials, as well as their verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. Okay, we're ready to go. I'll pass it on to you, both of you, to get started. But thanks again for joining us today.
Okay, I can I can start. So thank you everyone for joining today. So I will move on to our objectives for today, which are to assess the unique physiological and cognitive barriers to smoking cessation in geriatric patients, adapt pharmacotherapeutic and behavioral interventions for older adults, including those with cognitive impairment, and to navigate ethical dilemmas regarding patient autonomy, safety, and involuntary cessation. So we'll jump right in and start with a case. This is based on a patient I assessed recently. Obviously, some details have been slightly modified for this presentation. The case of Mr. C. He was a 66-year-old man. He is a 66-year-old man who's living in Toronto community housing. He does not have a phone, and he's extremely socially isolated. He is a long-term, quite heavy smoker since age 15, currently smoking 1.5 packs per day. And he presented to our CAMH emergency department with suicidal ideation after abruptly quitting smoking after he had a dental procedure and was told that he cannot smoke after the dental procedure. He knew about ways to access NRT through the STOP program, but because of lack of a phone and lack of a computer and lack of ways to kind of organize himself, he was just not able to access adequate NRT. He bought some, but it was not adequate to hold him. He also is medically complex, hypertension, diabetes, history of coronary artery disease, COPD, pain issues, and psychiatrically complex as well, has a long-standing history of depression, anxiety, and has had past suicide attempts. So as we go through our presentation today, and as we talk about kind of assessment of the older adult smoker, I want you to kind of think back to this case and think about some of the aspects that might come up for Mr. C. So thinking about smoking in older age, it's common, right? So this is Canadian data. If we look in that kind of 65 to 74 age group where Mr. C would fall, the prevalence of smoking is 12%. So that's going to be more than 1 in 10. The prevalence does get lower as we go to our older cohorts, right? So in the 75 to 84, it's 6.5%, and the 85 plus 2.8%. And there are probably a few reasons why we see that prevalence going down, right? People may be more likely to quit as they get older and accrue kind of health issues. And there's also probably some piece that people who are older and who are smokers have many health issues and pass away at these older ages. Marilyn?
This slide demonstrates the sort of one of the concerns around quitting, and why do we ask people to quit in late life? You know, is it too late? Things that we know is that not smoking is a wholly preventable cause of dementia, and so it's worth having that conversation with you know, your patients or your residents in long-term care to talk about it in terms of the health benefits and what are the things that can happen with smoking cessation. And if you look at it, it's 5%, which is fairly high when you look at all the other preventable causes: air pollution, alcohol, social isolation, depression. 5% is a fairly high number. So it's something to take consideration to. And if you think about it, we ask, you know, in our interviews about heart health, respiratory health, but we're not asking about brain health. But certainly smoking does contribute to cognitive impairment in later life. And we see here that the tobacco-related healthcare costs in Canada, that of all of the substances, so alcohol, tobacco, cannabis, opiates, and other drugs, it is tobacco that has the highest related healthcare costs in Canada. And if you look at the burgundy bar here, you'll see that it's the old at age 65 plus that has the highest per capita healthcare costs. So, and again, when you know, these are smokers at the end of life, and I'm not surprised to see the data at, you know, of the old adults that the rates of smoking are going down, again because of mortality related to smoking related illness. Next slide. So quitting is a process. 40 years. They start at age 25, and for some people that's quite late, but now they're 65. That's with 25 cigarettes a day over 40 years. That's 365,000 cigarettes, and 4,380,000 hand-to-mouth repetitions. That's a lot. And so we're asking people to make changes after all those years. And then when you can't, when you add dementia on top of that, it makes the quit attempt a little bit more complex. Next slide. So there's lots of health benefits. I'm preaching to the converted. I know all of you are trained out there, so there's lots of health benefits. But the one thing I really want to take a pitch for is the next slide, is that in a long-term care setting or with somebody with frailty and wounds, that if they're able to stop smoking, that wounds will heal better. So, and as you know, sometimes if people have had amputations, for instance, having someone making a quit for smoking at that time will help with their healing as well. So it's really, really important conversation to emphasize the benefits of quitting when there's serious illness and wounds that need to be healed. Next slide. So there was a study that recently came out of the UK, Dr. Bloomberg, and she spoke at our geriatric addiction rounds this year, and she found that middle-aged smokers and older smokers, they had similar cognitive trajectories, but smokers who quit subsequently had more favorable trajectories than continuing smokers, regardless of their age of cessation. So, and older adults are less likely than younger people to attempt smoking cessation. And so there's improvements in long-term cognitive trajectories. And so that might provide some additional motivation to quit. So, again, that's another great thing, a hopeful message to older adults that if you stop smoking, sometimes that your cognition can change. Very much like with Wernicke's-Korsakoff, or someone who's got an alcohol-related dementia. When they stop drinking, they can improve dramatically, and at worst they don't decline. And I think that's what we're seeing in this research, that the older smokers that quit, they don't get any worse at the very least, and sometimes get better. Next slide.
And this slide talks kind of along the same vein about the mortality benefit of smoking cessation, even in older age. So we'll talk later on around, when you're assessing an older adult who may be thinking about smoking, and they may have misperceptions about, how beneficial is it really to quit at this age or at this time in my life. If we look at this, I won't kind of go into detail, but even for people who quit in that age, like 60 to 69 group, so like Mr. C, right, there still is a mortality benefit conferred compared to those who continue to smoke. So even someone who quits in their 60s is at less risk of death relative to someone who continues to smoke. And of course, the younger they quit, the greater the benefit in that way.
So in terms of nicotine withdrawal, we know that older adults that are heavier smokers are going to experience some withdrawal, and particularly in situations where they might be sort of withdrawn from nicotine. Hospitalization, admission to long-term care, or to retirement residence where they can't smoke. So these are the things you want to watch for immediately. So cravings to smoke is obvious, frustration, anger, difficulty concentrating, restlessness, and that happens within a few hours of stopping, and it peaks within 1 to 4 days, but it can last up to 6 months or longer. So keep that into consideration, because this is a long journey for older adults. And some of the things that you also might see is nausea, diarrhea, shakiness, dizziness, fatigue, sleep disturbances, and headaches. And again, consider that in assessment of the behavioral and psychological symptoms of dementia. So it can be a challenge. And so what you may be seeing are symptoms of withdrawal versus the behavioral and psychological symptoms of dementia. Next slide. So when we assess older adults, it's certainly there's lots of tools out there, and I usually with somebody who's living in the community, I'll use the Fragerstrom. So we're looking at how many cigarettes per day they smoke, how, from the time they wake up, are they having a cigarette as soon as their feet hit the ground? Are they able to wait until after breakfast? Are there times when they've had previous quit attempts? And then what happened when they started back up again? And oftentimes I will hear from people who said, oh yeah, I stopped for 3 months one time, but I was in hospital. So it was kind of a forced quit. And there are some, motivational interviewing and get people's sort of motivation to quit. But if you think about, an older adult with a frontal temporal dementia or Alzheimer's that don't really understand and appreciate, can't remember that they even used to are actively smoking, they may say, I'm not smoking. So the Fragerstrom tests and asking them about their smoking history, you probably need to get information from collateral sources. So I wouldn't not.
Is Marilyn frozen?
Yeah, she's frozen for me
Okay.
too.
I will continue then while Marilyn reconnects. Oh, Marilyn,
Okay.
You're back.
You just cut out a little, so we didn't catch what you said for this slide.
Okay, so I'm just saying that in terms of motivation to quit for somebody. Okay, I'm going to turn my camera off. So so in terms of motivation to quit for somebody with dementia, you wouldn't refuse to treat. You wouldn't not give them nicotine replacement. You would continue to support and make sure there's a smoking cessation that help them their quality of life. Okay. So so you want to look at what are their medical conditions. Have they got COPD, cancer, diabetes, chronic pain, renal, liver function, and drug interactions? What are their physical limitations? Do they have pain, sensory impairment? Are there tremors, frailty? Can they hold a cigarette safely? That's one of the things that I always look at, is their safety to smoke. If the person is, aware of their surroundings and able to make sure that they're extinguishing their cigarettes safely. So next slide.
And then thinking as well about the older smoker, just adding on to Marilyn's piece here on sensory impairment, it's important when we think about, their safeties to smoke, but also when we start to think about tailoring our interventions, right? So if someone has like hearing impairment, how will that affect our ability to kind of provide behavioral interventions? When we're doing our assessment, are they just saying yes to everything because they can't actually hear you? And are we getting reliable information, right? So this is all information that's part of our assessment, but also with a good reason to help inform our treatment plan. We're thinking about cognition, right? So I've listed some kind of tools like the Montreal Cognitive Assessment, the MMSE, but also just getting a sense, is the person like generally oriented? Do they know how old they are, what year it is, right? Are they giving reliable information? What's their function like, right? So we talk about things like basic and instrumental activities of daily living, but focus on things like medication management, right? Like we can prescribe them or recommend, the fanciest regimen of medications, but maybe they're not actually able to take their medications properly, right? So again, thinking about this in our assessment, because it will inform our interventions that we're going to suggest. Are they able to manage and keep appointments, right? All these things are important. And then there's psychiatric history. So thinking about someone like Mr. C, right, who has this history of quite severe depression, quite potentially lethal suicide attempts, and how might nicotine withdrawal, that increased kind of like anxious, agitated state, contribute to his risk and inform our interventions and level of monitoring that we need. And then along similar lines, kind of their social and environmental circumstances. Are they socially isolated? Are there caregivers around who again, can be an important part of our interventions? Do they have access to transportation, money, technology, right? Many of the interventions we talk about are technology-based, right? People rely on internet, computers, phones. Are there other smokers in their environment? And then really kind of getting at what are their personal goals? What's their own, if it's someone who's cognitively intact enough to kind of be able to talk about this, right? What's important to them in terms of their reasons to quit, right? Is it to feel better, to have more comfortable breathing? Is it to save money? Is it be able to spend more time with family, right? Do they have a new acute medical illness or a new diagnosis that's really kind of increased the sense of urgency to quit smoking now? So really getting at that, again, to help inform our treatment planning. So back to the case, I'll just provide like a kind of quick closing of this case, and we have some more cases coming up. So because of his kind of degree of suicidality and his high risk for suicide for Mr. C, he had many risk factors. He was actually admitted to our geriatric inpatient unit. It was a brief admission. His depression was treated with medications and counseling. His nicotine withdrawal was addressed, right? So he received the nicotine patch and inhaler with good success. And then a lot of focus during the admission was on kind of the social environmental piece, right? So he was connected with case management. He was provided with, or his case manager actually took him, and there was a program where he was able to access a low-cost phone, and referrals were made, connections were made with the support of the hospital environment for follow-up with the STOP program to maintain his abstinence from cigarettes. So I actually saw him in psychiatric follow-up 1 week post-discharge just recently. And at that point, he was doing quite well, continuing to use NRT and had remained abstinent from smoking. Marilyn,
So
are you
some
there?
of the
Yes.
Yeah, some of the behavioral techniques. So we're looking at, in terms of counseling, using simple language, repeating visual cues, large print for people with visual impairment, pocket talkers for people who are hearing impaired. But also, especially for people with cognitive impairment, you want to look at the environment. How can we change things in the environment? So not having cigarettes or ashtrays or any smoking paraphernalia around that would cue the person to smoke. And keeping them busy with activities that maybe stimulate hand-to-mouth action. So drinking cold water, those are sort of typical things that you see in smoking cessation, eating raw veggies, but also, having a lollipop. That was one of our favorite ones during the pandemic, to use a lollipop, because it mimics that hand-to-mouth motion. And as we know, a little bit of sugar helps the medicine go down, and sugar will fix a craving. And one of the things Aviva had mentioned that one of her homes does to reinforce smoking cessation is they celebrate the progress, and they have a cake to celebrate the person's progress in smoking cessation. In the community, certainly caregiver involvement is key, especially where there's cognitive impairment. You need the family members to be on board to help with medications, to help make sure that the NRT is given as prescribed, and because some people will forget to put the patch on, and so having family there to help out with that, but also knowing that if mom or dad takes the patch off, that you have to watch for that, or else put that patch in the middle of the back where they can't reach it. So next slide. So again, sugar is a good one. Keeping candy in a nursing station. Those Werther's candies are always handy to have. They're nicely wrapped. Keeping a few candies in the person's pocket or a purse. Again, so that when they go to reach for the cigarettes, then there's something there, and they can open up a candy and have the candy to help manage the craving. We also used in long-term care adult coloring books. Again, keeps the hands busy, and a small chocolate or pop. Be careful with the pop though, because there's caffeine in it. So we encourage the use of decaffeinated beverages. And these are all done in addition to the use of nicotine replacement, whether it's long acting or short acting. Next slide. So again, with older adults, the one thing that we get concerned about with the gum is that if people have dentures, it's really difficult. You have to be able to chew it, park it, or in using the lozenges, you have to put it in your mouth and suck it and park it. And so it may be challenging with cognitively impaired, so they might chew it and swallow it. So that's not good. The inhaler is good for people who are cognitively, they don't have teeth or they have dent. So it can be good, but you have to watch to make sure that they can, put the inhaler together and that they can use the inhaler properly. I often get people saying, well, the inhaler's not working, and it's because they're inhaling it as opposed to puffing it and holding it in their cheek. Mouth irritation, GI upset, and again, if it may be that someone cognitive might not be able to express that that's what's happening to them. Next slide.
And then with respect to medications and prescribing, just like anytime we're thinking about medication use in older adults or really in anyone, we have to think about what are their kidneys and their liver function like. We have to think about what medications are they on, and older people very often are on many medications. We have to think about polypharmacy. We have to think about drug-drug interactions. And as much as possible, we want medication regimens to be simple, right? We want to think about if there's a 1 time a day option rather than a 2 or 3 times a day option. Do people need things like blister packs or bubble packs to help with their medication adherence? Can we put systems in place to help people remember? And as I think this kind of come up many times, right? Like caregiver involvement can be really key, because we can prescribe all we like, right? But if someone's not going to take their medications or not going to take it properly, we're not really doing too much. And then some just specific considerations for some of the pharmacotherapeutic options. So I think we've talked about, or Marilyn's talked about, some of the special considerations for NRT. When we're thinking about bupropion or Zyban, this is a medication that lowers seizure threshold. So if there's somebody with a seizure disorder or a vulnerable brain who's otherwise at higher risk of seizures, this is something to think about. Varenicline does need to be dose adjusted if somebody has renal impairment. And then cytosine, which is newer, we don't have as much experience in the older adult population.
So this is a gentleman that I worked with in long-term care home. He was 70. Sorry, not a gentleman, it's a lady. Too many cases here. So 79-year-old female, and she's got a medical history of diabetes. She's got frontal temporal dementia. She's got a wound on the right leg, and that's not healing. She's a 20-pack a day smoker, and the family does not want mother to be deprived of her cigarettes. That's all she's got left, and she just would die if she didn't have cigarettes. But what's happening is the resident's agitated and verbally responsive. She's asking to go out and smoke in the middle of the night. That's not possible. And so she's been found smoking in her room at night 3 times. And so we know that when the family visit, they give her cigarettes. And then the staff ask her to hand over the cigarettes and lighters when she going back to her room, and she refused to do that. And she's had this happened 3 times. So they contacted me, and we were looking at a tailored approach to smoking cessation for her. So next slide. So what happened? One of the things that I like to do is on the spot is to offer the choice, a menu of options. I bring all the different products with me for the person to try right on the spot. She was given a nicotine lozenge, and she liked it, but she still missed that hand-to-mouth motion. But she said she prefers to have the lozenge, and she was really surprised that she was quite skeptical when we first met, but she again was missing that hand-to-mouth motion. So we gave her the nicotine inhaler with no nicotine in it, because we also knew that she might forget that there's nicotine in it, and she might keep puffing on it and then end up with nicotine toxicity. So and then the other thing is that when she was asking to go out, the staff if she would like to have a lozenge. And so that was working fairly well, but they noted at nighttime she was becoming more and more agitated. She was up and wandering, and she herself was reporting poor sleep and having vivid dreams. So we removed the patch at night, and she's still not sleeping well. Next slide. So what else is going on? So on further investigation, we noted, I mean, I was sitting with her at her table, and she's drinking a cola, a Coke. And it turns out that she's 6 cans of cola per day. And so we had to, again, use decaffeinated beverages using a slow taper, because that was her habit. And again, family members were pretty reluctant, and they would bring in caffeinated cola for her, and the staff would have to sort of switch out half and half with decaffeinated, and continuing to use the 14 milligram patch and the empty inhaler. And overall, it worked because she was comfortable, and didn't say that she had to quit completely. It was about her comfort. And so we said, if you want to go out and have a couple smokes with your family when they visit, that's fine. But we just want to make sure that when you're inside, you're comfortable. If you have an urge to smoke, we want to make sure you're comfortable. So right now, there's no more subversive smoking. She's sleeping through the night, and that's the one thing that she was really surprised with, that taking the patch off at nighttime and cutting down on the cola, as well as not having to wake up in the middle of the night for nicotine withdrawal. She's really feeling good about that, because she hasn't slept well in years, because she's always gotten up in the middle of the night to smoke. And again, we said to her, we're focusing on the comfort, not a full quit. Was stay cutting down, and even though the family member doesn't want to stop. So next slide. So the interesting thing as well is to take into consideration when you're stopping smoking, when you're no longer having combustible tobacco, that caffeine is processed differently. So it's processed significantly slower. The tobacco smoke contains compounds that induce liver enzyme CYP140A2, and it accelerates the caffeine clearance. So when you don't have the combustible tobacco, the enzyme's activity normalizes. And so what happens is that there's a doubling effect of caffeine's half-life, and potentially leading to toxicity. So remember, this lady was drinking 6 colas a day. Now she's not smoking as much. She's only smoking like 2 cigarettes perhaps a week. So it's like she's having 12 colas a day. And same goes for coffee. So keep that into consideration when counseling people around smoking cessation. So that was a really good learning for us. Next slide.
So I think as we can see from these sorts of cases, right, these situations are really tricky, right? There's a bunch of considerations. There's often no kind of one size fits all or one correct approach. And there are a lot of ethical considerations to think about. So if we think about this sort of situation with some very basic like ethical principles, if we think about autonomy, right, someone's right to make, we do have to respect an individual's right to make an informed decision if they're capable to do so, right, and turn to an SDM if incapable. I think often in the work I do, whether it's related to smoking or psychiatric medication or managing money, one of the things that we're often humbled by is that people are allowed to make capable, but what we might think are foolish or not wise decisions, and kind of taking a step back and being able to accept that. At the same time, there's a principle of beneficence, right? Like doing good, promoting, improving health. So recommending evidence-based smoking cessation treatments, right, that we have available, and managing withdrawal symptoms. There's also the principle of not doing harm or minimizing harm, right? So again, managing withdrawal symptoms and addressing safety, right? So autonomy is important, but so is keeping people safe, avoiding harm, right? Thinking about, in this case, risks of fires, burns. I think someone mentioned in the chat oxygen therapy, right? There are very significant safety concerns that can arise. And generally thinking about in these cases, how do we balance the rights of the individual with protecting others and preventing harm? In cases of involuntary cessation, so if somebody's hospitalized, right, or moves into long-term care and is not able for whatever reason to smoke, right, it's pertinent to manage and prevent nicotine withdrawal, right? And I think one of the important concepts is that these cases are often not an all or nothing approach. So as Marilyn just described, it wasn't 100% quitting smoking, right? It was preventing harm, right? Doing what we can to maximize safety, but also keeping her comfortable and still giving her, you know, access to cigarettes in certain circumstances, right? Marilyn, the next case.
Okay, so gentleman who again was referred from long-term care set. He has dementia. He's 80 years old. He's been smoking for 65 years, and he's been living in long-term care for several years, been a safe smoker so far, but his cognition has declined and behaviors, and he's been found smoking in his room. And so the staff again said, well, we're going to hold the smoking materials, but the resident wasn't cooperative and then became physically responsive and pushed a nurse. So in that case, he was then placed on one-to-one support, and so that he had somebody with him all day long to make sure that he wasn't lighting up in his room, and also that he wasn't, being angry with the staff. And again, family members, you know what, I have to say that it's usually, I get more pushback from the family members about smoking cessation than I do the older adult who is, who is cognitively impaired and is really not, they're open to looking at the options, whereas family members are saying, no, mom and dad want to smoke. Again, it's that last remaining pleasure. So next slide. So the interesting thing with this gentleman was, how do we ethically and smoking cessation when the family members are reluctant? And what are the risks if the resident continues to smoke? So I'm going to ask, what, in the audience, what would you do? Family members say, no, dad needs to smoke, and the one-to-one is there, and they can take him downstairs and he can have his cigarettes. But that's really not sustainable. Can people unmute, or they just type in the chat box?
For this, type in the chat box would be great.
Yeah, so Sarah says, try to find out more what smoking means to them. Anything else? Yeah, so helping the family members to understand, do a little bit of teaching with the substitute decision makers. And look at, yeah, all really good. Yeah, the fire hazard risk, that's a really important one. It's and I've actually, this is the third time that the fire department has come to the long-term care home, and the home gets charged for the fire truck to show up, and I think there's a $2,000 fee, and also there's a ministry citation, and so they have to be accountable to the ministry. And so I asked the family members, once is an accident, twice is questionable, and 3 strikes you're out. And I think how would you feel about having to pay that? And so having really frank conversations about the safety risks is important with family members, and again focusing on we want to make sure that mom or dad are comfortable. So I missed that last one in the chat. Rachel, can you read that one?
With the motivational interviewing with patient, find out in their own words how they feel about potentially quitting. Ask if you can share their feelings with family.
Yeah. And that's if they're able to verbalize that they want to quit. And again, so I first talked with them about the benefits of quitting, and I'm saying that you don't have to stop, but and again, it's really good to have the hands-on products there for people to try on site. So, okay. I think, yeah, Margie, refer to Marilyn. Yeah, so having a family members, getting everybody on the same page is often helpful. Equally sort of ranking substitute makers, and 3 of them are smokers and 2 are not. There's maybe some undue influence. So, but the one-to-one is not sustainable, that's for sure. So next slide. Next slide. So anyway, so when I met this gentleman, came into the room, I could tell he'd been smoking in his room, and I don't know how that happened with the one-to-one there, but he had been smoking in his room. But he came in to see me. We were in his room. He sat down, but he had a cigarette in his hand and he had his lighter in his hand. So he was ready to go out for a smoke. And you know, when you talk to somebody who's a smoker and you start talking about smoking, it often triggers them to want to have a smoke. So I've got somebody who's anxious and does not want to see me. So I spoke to him right away. I said, can I talk to you a little bit about what's going on with you? I understand that you're a smoker, you like to go out for a smoke, but smoking in your room lately, and that's a little bit of a... So can I talk to you a little bit about how nicotine replacement could be helpful and make you comfortable? And all of this was done with an interpreter, by the way. I don't speak his language whatsoever, and I had, you know, a little 10-minute window with this gentleman. He agreed, and he did do a trial of the nicotine spray, so with his permission, and he had the worst visceral response I've ever seen to the nicotine spray, because some people will say, oh, that tastes terrible. This gentleman, he took a glass of tea or orange juice that he had, and he rinsed his mouth out and he spit it in his denture cup, and he said, oh, that's awful, that's awful. And he said, I feel sick, I'm gonna vomit. And so I said, oh, I'm really sorry that doesn't feel good for you. So and then I said, about 30 seconds later, I said, how do you feel? Do you feel like you need to go out to have a cigarette? And he stopped, and again, this gentleman has dementia. I said, do you want to go for a cigarette, or can you stay and wait with me for a few more minutes? And he said he'd be okay to wait. And so he actually, within a minute, the spray was taking effect, even though he had rinsed his mouth. And he was then started to be quite calm and cooperative. And then when I go to leave, and I said to him, you know, can we talk about using some nicotine replacement? And I told him about the patch, or, you know, if he likes the spray, we could see if we could get some spray for him. And again, he doesn't speak my language. I don't speak his language. And he comes up to me and he tries to take the nicotine spray from me. And I said, I can't give it to you, but I'll leave it at the nursing station. So the nurse told him that, and he said, okay, that's fine. And so he and the one-to-one went outside to smoke break, and I fully expected him to have a cigarette. And I went downstairs and I spoke to the BSO lead, and I said, I don't know, we're probably going to have to use the nicotine patch, but you know, he's not really happy with the nicotine spray. Usually is pretty effective. And the resident and this one-to-one came back in about 10-15 minutes later, and I asked the one-to-one, I said, did he have a cigarette? And he said, no, he just sat there. We just sat there and watched the birds and had a little bit of fresh air, and then they came in. So it was evidence to us that the nicotine spray was working. So again, I was able to relay that information to the family members, and I said, well, it's not, we're not asking them to quit. It's not about the quit, it's about the comfort. And when the family members realized that there was something that would make them comfortable, then they were more on board, and they actually went on to support smoking cessation with using NRT. So next slide. I want to give out a shout out to CAMH, to the CAMH Intrepid Lab, because we have, for those of you who work with people in long-term care, we have the Stop in Long-Term Care, which is a program that gives no-cost nicotine replacement therapy to residents of long-term care. And so you can scan that QR code if you like, and that should take you to the link. Go email stop long-term care at camh.ca. The other thing that the STOP program does that's really great is they also offer smoking cessation nicotine replacement products to staff of long-term care homes. And the reason is that the smoking rates for healthcare workers is high generally, but it's highest in the long-term care sector. So, and you've got people who are smokers and going in to provide care to people who cannot smoke or want to smoke, and they can smell the smoke on the staff's breath or on their clothing, and it can be very triggering and cause some behaviors. So, so if you are a long-term care home and you're not signed up for the Stop in Long-Term Care, please reach out to CAMH and we'll get you set up. So next slide. So we've got about 13 minutes for questions.
There were some that people had pre-submitted or put in the chat throughout the presentation that I can read out. But if anyone else also has questions, feel free to include them in the chat while we're answering these. But there was something that came up that said, at what point do we accept the patient will not change their smoking behavior?
Well, again, I think my feeling is that it's, you know, when there's risk, serious risk, that have ended up in the hospital, you know, it's because of risky smoking. And so, you know, it's at some point there has to be some recognition of the seriousness of the risk. But if somebody is, you know, they've got some health issues, they're cognitively intact, they're a safe smoker, and they absolutely don't want to stop smoking, then we don't, you know, you're not going to push them into it. And certainly in somebody in the community, it's a little bit harder because you've got friends and family members that are around and smoking, and again, with cognitive issues, they may, you know, if you take away the cigarettes, then they may elevate the other risks, which is, you know, going around picking up cigarettes on the street, or you know, stemming for cigarettes and then ending up being, you know, hurt or something like that. So you know, so that's a delicate balance.
The other piece I would add is that, like, again, it's not all or nothing, right? So it's not quit smoking or not quit smoking. There's a, you know, looking at safety, can we make things safer, right? Can we keep the person comfortable, which might mean not necessarily quitting smoking altogether, right? But finding somewhere like a middle ground. Like I often see in long-term care, you know, if they'll ask someone or they'll ask their, you know, their substitute decision maker, do you want to quit smoking or do you want them to quit smoking? And if the answer is no, they then just kind of stop altogether and don't go on to kind of offer NRT, right? So someone doesn't have to want to quit smoking to be offered NRT or other available treatments.
Thank you.
Yeah,
there was
we
sorry.
actually had, again, could I mention that we'd had somebody who had a really serious burn, and they were they needed to, if they were going to go out for smoke, they had to have 1-to-1. And so we came to an agreement with the long-term care home that this would go out 3 times a day, and there would be somebody, a staff that would go out, and usually the staff smokes anyway. They would go out with her 3 times a day, but she to have the nicotine patch. Other than if she didn't have that, she would be smoking inside in her room with somebody who's got oxygen, and you know, and again with that history of dangerous smoking, risky smoking, when the person was outside, her hair caught on fire, and she wasn't able to walk fast enough to get inside, and by the time she got inside fire, they had to throw her to the ground and put the fire out. So, but still, that wasn't enough for the family members to say, you know, Mom has to stop smoking. It's, you know, we still want Mom to have her autonomy to have a few smokes.
Thanks, Marilyn. There was another one that said for caffeine effects, is the liver enzyme activated with vaping as well, or just tobacco smoke?
I think it's not the nicotine. Well, first of all, we don't necessarily know what's in the vape, right? But it's the tobacco combustion, like some product of that combustion process that then induces the liver enzyme. So I don't necessarily think it would be the same with vaping. It's not the nicotine itself that has that liver enzyme effect. But again, like we don't know what's necessarily in the vape, so it's a bit tricky to know.
They're still burning, right? There's still burning that goes on in the coil of the vape, so there might be some, probably less so than. I don't know the evidence on that.
And another one that was pre-submitted was, I have a client who smokes 1 pack of cigarettes per day. She has a history of diabetes, depression, and high cholesterol. What would be the most important thing I should consider?
I guess I'm not sure if there's like a specific piece of the case that you're wondering about, but I think it's important to start with like where's this person at, right, in terms of their motivation to quit and their potential reasons for wanting to change their behavior or not, right? So that might be a good starting point. I don't know if you have any other thoughts, Marilyn.
Well, again, with people who have diabetes, where there's sort of increasing frailty and the one thing I see quite often is the wounds or the gangrene that's been caused by poor circulation, and or even just generally having poor circulation. And so that might be something to talk about the health benefits and how what are the things that you could be doing differently if you weren't smoking. There's a really good tool that I use online, and it's sort of a put in the number of cigarettes a day you smoke and how much it costs you a week and how much it costs you over a year. And so sometimes having a conversation around the money piece can really impact people and saying, gee whiz, if I had $300 extra a month, that's a fair chunk of change. And so, there might be a bit more willingness. It's not related to the diabetes, but, it's something that can motivate people. But certainly with the health effects, the risk for, because of the circulation problems, the risk for, gangrene and amputation is in this population is pretty, it's not uncommon.
Okay, I'll move on to the next one, which was, what strategies might you have for working with a client with cognitive impairment over the phone?
That's a tricky one. I mean, it depends, I guess, the degree of their cognitive impairment, right? But I think some of the same principles apply in terms of, is there a caregiver who can be involved? So if they're in long-term care, right? Like, are you just speaking with the client, or are you also having a touch point with the staff in the home, right? Are they able to hear you on the phone, right? And then the same kind of ideas around short, simple, clear language, repetition, right? But I think if this person has cognitive impairment and is in a setting like long-term care, this is a really, like, staff need to be involved, or a caregiver needs to be involved to support as well.
I wanted to mention that the Stop on the Net program is available to anybody, but somebody who is cognitively impaired wouldn't be able to go through that process. It's a little too convoluted for somebody to go through that. And so I have had family members, with permission of CAMH, the Nicotine Dependence Clinic, for the family members to apply on their behalf in order to access the no-cost nicotine replacement. And it's you know, and so it's the family member that's supporting and making sure that the patch is on, or that their nicotine inhaler is loaded, and so on. So having somebody, a collateral source to take charge of the NRT. Having said that, when somebody's in the community and there's an application to long-term care, and there's, the person hasn't had a sustained quit, I think that it's still worthwhile to trial the nicotine replacement to demonstrate to the Ontario Health at Home coordinator that if the nicotine replacement is introduced, there's this person was comfortable, so there's some success, so that we know that once they get into long-term care and there's a consistent way of delivering making sure that they get the nicotine replacement, right dose, right time, that they're going to be successful and not have problems once they get into long-term care, especially if they have to be in a secure unit.
Thanks. There was one which is maybe more general, but it was just asking if you have any tips on connecting with patients and or staff in long-term care facilities in general, just general advice or tips that you would want to give.
Well, I know that geriatric resource consultants that provide education to the homes, they will often do education sessions on smoking cessation. And certainly in the Toronto area, I often get invited by our BSO nursing leads or by the PRCs to come out and do some education. And I had a really funny experience with when we did some education at one of the long-term care homes, and I could tell there was one staff that was really, really antsy, and they wanted to go for a smoke, and they had been asked to come out on their lunch break to listen to me talk about nicotine replacement. And the first thing I said is, anybody here a smoker? And they, 3 or 4 of them put their hand up, and I said, who's really itchy for a smoke right now? And the one person who was wanting to leave to have a smoke, she put her hand up, and I said, well, come on up here, I'm going to give you something right now, and you can give it a try, because this is what your residents are going to be using. So I gave her a try of the spray, and I said, okay. I said, oh, yeah, she had it. She sat down, and I asked her in 2 minutes, I said, so how are you feeling now? And I said, do you need to go out for a smoke? And she said, no. And she goes, wow, this is amazing, I can't believe it. So, oftentimes having, conversations with the staff, educating them, and because, it helps them to understand and know what it's like for the older adult. Especially if the older adults, somebody who's a smoker, and then the older adult is in a position where they have to rely on the staff to go outside for a cigarette, or to get the staff have to get them up to get them out of bed to go and have a cigarette. And how uncomfortable that is, especially first thing in the morning. If you've been sleeping all night, you've gone 8 hours and you haven't had a cigarette, you're going to be grumpy first thing in the morning, and you wonder why the person is striking out at you. So knowing and understanding how the nicotine replacement can be helpful in those moments when people are really going through withdrawal, that can be helpful. And big learning experience for the staff, a big sort of aha moment usually.
It's great, thank you. I'm seeing that people are just saying thank you and have found this very helpful and insightful. And I want to say thank you as well, both of you, for coming in. I'll end off with a few final reminders, but I'm seeing some people have to go, and if anyone has to go at this point, that's okay. Thank you for joining us. I'll put Marilyn and Aviva's emails on the screen. If anyone has additional questions, feel free to reach out. You can also reach out to us at teach@camh.ca. And we will try to include in our wrap-up email that we sent everyone that information on the stop in long-term care too, if anyone has questions or wants to reach out directly about that. So yeah, just a few final reminders. Again, if you wanted to receive a letter of completion, the evaluation and post-learning assessment will be sent out to everyone who registered, and you'll have a week from when it's sent out to complete that. And our next Teach educational rounds will be on cancer populations and smoking cessation, and that's on August 12th with Dr. Lawson Enns. For now, thank you. Thank you everyone for joining. Thank you again for coming back to speak, Marilyn and Aviva. It was great again to hear your case studies, and I can tell everyone really enjoyed it as well, if you can see the chat too. But yeah, thanks everyone, and we hope you enjoy the rest of your afternoon.